request everyone to keep your mobile in silent mode and please take your seats. And those who are not registered, please get registered. The certificates will be given accordingly. Well, to give you an overview of the prevalence of fertility, we all know that infertility affects 10 to 15% of the couples, and that is around 30 million just in India. And how many of them approach the doctor? Just 1%. Why so? It's because of low awareness level and the myth that the success rate in IVF treatment or infertility treatment is very low, and also they are more worried about the cost factor. In India, the general notion is that it is the female who is responsible for infertility, so the male partner is generally ignored. At Oasis Fertility, we are proud to share that in the last 12 years of our journey, we have built one of the most respected institutions in the field of reproductive medicine in India and have helped over 35,000 couples to achieve their dreams. At Oasis, we pride ourselves on the impeccable standard we maintain in our lab, and it's a highly advanced lab. The lab is crucial for the treatments offered at our center, and we ensure that the highest level of quality is maintained here. Our lab is one of very few labs in India with proper and total quality control management. This optimizes the result of assisted reproductive techniques. We are the first one to provide advanced services like PGS, PGD, IVM, micro-TC, vitrification, and fertility preservation. Through advanced treatment like pre-implantation genetic screening and vitrification, micro-TC, the success rates can be improved. At Oasis, we treat many couples with a history of failed IVF and successfully offer better pregnancy rates. Well-trained, experienced team with state-of-the-art facilities has helped Oasis successfully offer advanced treatment all under one roof at Oasis. The objective of conducting this CME is to empower clinicians from across the city by the way of the interactive session on clearing the clutter in infertility. At the end of it, we expect the participants to get empowered with the knowledge and recent updates on fertility treatments and come forward to treat more and more infertile couples. So kindly sit back and relax, and we hope that the session will be liked by one and all. Over to Pranika.
Good evening, everyone. Before we start the session, we would like to kindle the light of joy. The light that shines speaks about hope. Doctors are called to do little acts of kindness which kindles hope in the heart of patient, be it a smile, a kind word of encouragement, or even a pat on the shoulders. So I would request our today's dignitaries, Dr. Durga Rao ma'am, Dr. Krishna Chaitanya sir, our panel members, Dr. Joylin Almeida, Dr. Vatsala Kamath, Dr. Gaurav, Dr. Pramoda ma'am, Dr. Aruna Kamath, Dr. and Mr. Sudhakar Raghav sir to please come on this stage, and Dr. Prashant Malla, our guest of honor today.
Vijay, और लाइट ऑन मत करो बच्चा तपेरा
सूर्यास्तं समारभ्य यावत् सूर्योदयो भवेत् यस्य तिष्ठे गृहे दीपः तस्य नास्ति तदेव शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदम् शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदम् शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदम् शुभं कुरु त्वं कल्याणम् आरोग्यं धनसम्पदम्
Excuse me, ma'am.
Thank you so much to all the dignitaries. Before we move on to our scientific session, I would request Mr. Sudhakar Jadhav, our Chief Operating Officer for Oasis Fertility, to speak a few words about Oasis Fertility journey. Over to you, sir.
Thank you so much, Pramoda. Good evening, all the guests here. In fact, we are quite excited to be here in Mangalore. It's a very great day for us because back in the day, we just inaugurated our Mangalore facility. Before I could talk more about Oasis Fertility, Dinesh, if you could play the virtual video, I would like you to take to the tour of our Mangalore facility.
This one you don't, right? No? This one don't, right? No?
Thank you, Dinesh. Speaking about Oasis Fertility, we were founded way back in 2009, so we just got into our teens actually. So we are about 13 years old currently. This was founded by Dr. Durgaji Rao, who is with us today. She's one speaker today, and Mr. Kiran. And we are a ICMR registered and ISO 2001 certified organization, and currently we are going through the entire ART, the new law of 2021, and will be regulated and will be getting the ART licenses soon. Then in fact ranked number one in South India consistently for last 7 years, and we have been the most trusted fertility experts in South. These are our pictures of both co-founders, Dr. Durga Ji Rao and Mr. Kiran. In fact, we also have Dr. Krishna Chaitanya, who is an important member of Oasis family. He's scientific head and clinical embryologist, so he's also one of the speakers today. Well, we have been leading the space, the entire ecosystem of IVF space in the country. We currently operate about 25 centers, and our aim is to look at about 40 next 1 year's time. I think awards has been way of life for us. This is the most recent award about a month back, where we got one of the best healthcare brands by Economic Times 2022 in Delhi last month. And these are all series of awards, just a ego feat for us here. Well, I think we are extremely patient-centric organization. For us, I think the most important member is the customer or the couple on the floor. And our NPS score has always been more than 85%. And trust me, I think next 5 years down the line, it's going to be word of mouth, which is going to be a very crucial, what do you call, instrument in terms of getting more patients to to your clinics or to your hospitals, because your marketing or BD is not going to work 5 to 6 years down the line. Just word of mouth, your service excellence is going to play a very important role. These are our ethos. I think everybody, right from Durga ma'am to all the clinicians and embryologists, we strive very hard to give a biological child to the patient, and that's the reason why I think our donor cycles are very less compared to our self IVF cycles. We are not in the rat race to become a number one or a number two. I think we would like to be the most respected fertility enterprise in the entire IVF space. So that has been our value and ethos, and that is what we'll be following. And we are being the most trusted expert in fertility treatments. In the video, we are seeing some of our values, that is compassion, being competent. All our treatments are totally customized and individualized patient-wise. We maintain a patient confidentially, of course. And electronic witnessing system is something where the entire value of being careful comes in. For us, I think being credible is more important, and then commerce follows. These are two extended values for us. This is the snapshot. This slide actually tells everything about Oasis Fertility. On annual basis, we do close to about 15,000 IVF cycles, 20,000 IUI cycles. So far, we have treated more than 50,000 couples. We have a collective experience of more than 300 experience when we put all the experience of our clinicians and embryologists. And our success rates are well above the global standards. We have a strong employee base of more than 600 plus employees today. And then every center of ours has dedicated embryologists. We don't do batching at all. We don't believe in batching at all. So this is typically the snapshot of Oasis Fertility. And as I told you, I think for us, quality is the way of life. We stick to the highest quality standards. We are an NABH accredited organization. Some of our facilities are going in for a QA accreditation, and we are a member of ASRM and FOXY. All our labs have class 10,000 environment. We have centralized AHUs with HEPA filter. All our consumables are MEA tested for toxicity, and all our labs are fundamentally state of art. In terms of the new law, we are fully compliant. We run level 1, we run level 2 clinics. We are going through the entire inspection process. Some of our facilities are going to get licenses for surrogacy as well as for ART bank also. I think this is something which is very new subject, and every ART center is actually going through this. Wide spectrum of services. I will not spend much time here, but I think a couple of them I wanted to highlight. I'm sure Dr. Krishna will speak more about it. PGT, pre-genetic screening, is something which we do in highest numbers in the country, and we are very proud to say that. And the second important thing is the micro TC, which is part of our male fertility treatment regime, where I think we have been doing highest number of micro TCs so far in the country today. These are our the success rates. Particularly if you see our frozen embryo transfer rates, I think our success rate are almost close to about 69%, and we have actually exceeded the worldwide standards. Well, this particular slide explains how we work in terms of when we get a patient from any referring doctor. We ensure that the patient goes back to them because we just do fertility. We are a daycare clinic. We just help the couples to conceive. Once the patient conceives, we ensure the patient goes back to the respective doctor. So that's our very important value for us. Right? This slide talks about our information system. We have a very intelligent system called Artist. It's a smart suite. It's a cloud-based system where entire information of the patient is actually kind of keyed in, right from the first visit to the patient till the couple conceives the baby. The entire journey of the patient is actually captured, right from first phone call, in fact. So we have the total information of the patient, and we are proud to say that today we have got close to 60 or 70,000 patients database, and this is actually enabling us to embark on our AI journey. AndroLife, this is our exclusive male fertility clinic. I'm sure you'll all agree with me that today fertility is just not a female issue, it also affects 50% of the male, and in fact 50% of our patients actually have this male fertility issue. That's the reason why we have started AndroLife, and we run AndroLife in each and every facility of ours across these 25 centers, and we have been doing different treatments under AndroLife. These are some of our new initiatives. IVFparents.com is something like Google for fertility patients. Once somebody goes here, they will find the entire information. It's primarily a patient education portal. So this is something which we are developing. This happened during COVID days. This was one of the necessities which we started IVF at home. We understand that everything cannot be done at home, but at least 60 to 70% of the job was done at home in terms of giving the injections to the patient so that the patients comes fewer times to the clinic. So this was one of the initiatives. Happy to share that we believe in giving back to society. Amulya is our CSR initiative, which means that any poor patient who actually comes to the clinic, we give free of cost treatment to the patient. So in case if you have any poor needy patient, please send us to our Mangalore center. We'll be happy to help them. Training and academics, very close to Dr. Durga ma'am's heart and Dr. Krishna's heart. In fact, we have 2 DNB seats every year. We run our own fellowship program. Currently, we have got more than 10 students, and then we run different short-term and long-term courses, both in clinical side and on embryology side. If anybody wants more information, kindly let us know. We're happy to give you that information. Last but not the least, this is a snapshot of our speakers today. Thank you so much. Over to you, Dr. Ramona. Thank you.
Thank you, Dr. Mr. Sudhakar. Now I call upon the first speaker, Dr. Durga Ram. She's the co-founder and medical director of Oasis Fertility, and she'll be talking about enhancing success and advanced fertility treatments, success stories of Oasis Fertility. And Dr. Durga Rao is she's a specialist in reproductive medicine and minimally invasive surgery with overall 26 years of work experience, a leading voice in the fertility industry and a pioneer in research and practice of in vitro maturation treatment and fertility preservation from the prestigious McGill University of Canada. Responsible for bringing in the most advanced ART treatment with an experience, competence, personalized approach, along with extensive knowledge, understanding, and compassion, played a big role in the success of the treatment offered at Oasis Fertility. Dr. Durga practiced in UK and Canada. She underwent professional training in UK and has several papers and publications to accredit and conducted and attended several conferences across the world. She is a big name in the world form of fertility doctors.
Good evening, everybody. The aim that we have is basically to give you a bit of a snapshot or a bird's eye view of what is going on in the fertility space. Now, when we are talking about fertility, we are a very young community. The first IVF child is only 44 years now. So we still haven't come up to the, half century of the field. But the amount of advancements that are happening in this space in this such a short amount of time is really breathtaking. If you really look at how fertility and the commencement of treatments began, it's been there from 1953. But like I said, the first IVF child was born in 78, and since then, every few years we have some advancement or the other. And the two most important aspects to fertility, which actually change the way we are doing treatments, is vitrification or freezing of gametes, and second is the concept of ICSI. Now, with ICSI, we have actually taken the whole male infertility into a completely different sphere. Now, when we're talking about IVF, in the world, more than 10 million babies are already there. Now, when we are looking at infertility, just to take us back to the basics and then move forward, 1 in 6 couples suffer from infertility, and the treatment always should be couple-centered. So we are moving away from actually only doing investigations for the woman, giving her the treatment. Right now, we only take in couples, and only if the man comes in with the woman during the history taking as well as for investigations. So no treatments, frankly, should be started without a semen analysis report. A woman should not be given a prescription till the whole investigation and analysis of the couple together is done. When we are looking at treatments, obviously the most important aspects are the duration of infertility, the cause of infertility, and the female age. The first step in fertility treatments is actually ovulation induction with timed intercourse, and this is usually offered to women who are less than 30, who have regular cycles, or even if they have irregular cycles, we are giving them ovulation induction, so that actually takes them through. But the most important aspect is we should take in couples only if the man has a normal semen analysis towards this treatment. Next comes IUI. The group of people that actually are offered IUI is when timed intercourse fails and they have patent tubes. Again, this is a must. So before we consider doing IUI, it's very important that some kind of tubal patency or test is done before we take them through this treatment. And also be sure that the sperm analysis shows at least more than 10 million motile sperm. Obviously, the woman should have good ovarian reserve, and the amount of time that we spend in IUI should never be more than 4 to 6 months. Because what tends to happen is the woman keeps going at different centers and different gynecologists, and each time we do 1 cycle, 2 cycles, then because it hasn't worked, she goes to the next one, then we restart the process. And by the time she actually comes to a referral center, she would have had more than 6 cycles of IUI. Then comes IVF. Who do we offer it to? Unexplained infertility, who've had multiple failed cycles of either timed intercourse or IUI. If the woman's age is more than 37, if the count of the sperm is less than 10 million, if there's a tubal factor, and if the ovarian reserve is also on the lower side. The latest indication for which we are seeing quite a number of people being offered IVF is severe endometriosis. Now, this is a progressive disease, as we know. Even though a woman is younger, we are tending to see a lot of young women less than 30 with absolutely very poor ovarian reserve. So we just cannot go by the age. We have to take the whole holistic approach. But the question that we want to answer today is, suppose we go through these 3 steps, and even with IVF a woman fails, then what is the next thing that we have to offer? So that's when advanced fertility treatments come. And this is again a laser shot of what is actually available in the centers. Now, with the advancement in terms of the culture media, in terms of the quality of the lab, in terms of the incubators that are available, we are able to actually progress the incubation of an embryo right up to the 5th to the 6th day, which means that we are able to develop an embryo from a cleavage stage to a blastocyst. We can offer women IVM. We can offer women PGT, PGT-M, and PGT-SR based on what the genetic condition is. We can help improve implantation by doing specific and very thorough endometrial assessments. But one thing that we should not forget is, till now, even though ICSI has been there for so long, it's only been the embryologist who, with their trained eye, is picking up the sperm to enable embryotic ICSI. But then again, when we are really looking at how best we can improve that aspect, because when it comes to the ovum, there's nothing much we can do. Probably, give them lifestyle advice, give them good quality gonadotropins, do the right protocol for them, and then you're aspirating the oocytes. But when it comes to the sperm, there's very little that was being offered. So the last decade, we are seeing quite a lot of improvement in terms of how to enable us to pick up the right sperm to help fertilization and quality of the embryo. Now, why did we even consider sperm selection? Is because over the years we have learned that the sperm, even though morphologically you might not be able to pick up a lot of abnormalities, the DNA that contains in the sperm, if it is fragmented, is actually going to result in lower implantations. Even if implantation happens, it can cause miscarriages. So how do we treat this? Obviously, we have to treat the man first. We have to see what are the causes of the raised sperm DNA fragmentation index and see how best we can mentor the sperm. But what has helped us over the last few years is various devices that have come on which help us identify and pick up a better quality sperm. There are different devices that are there, which is MAPS, that is magnetic activated cell sorting sperm, Pixie, microfluidics, and MC. Now, what we do in a Pixie dish is a very simple and not a complicated device. It's just a dish which actually has hyaluronic acid, and any of the sperms which are not fragmented get attracted towards the hyaluronic acid, which is at the perimeter of the dish. So you actually pick up the sperms that are binding to the hyaluronic acid. Then comes microfluidic chip. Now, this is again a device which works on the laminar flow concept. And in this device, what it does is it separates the sperm which have much more intact DNA than the other sperms. The best invention right now is MC, which actually helps you look at a sperm which is more than 6,000 times. So you're actually able to look at the organelles of the sperm. You're able to see vacuoles, you're able to see the acrosome. You're seeing the sperm structurally, which enables you to pick up the right quality sperm to do ICSI. Then comes MAPS. Here, what happens is we are using annexin beads. These annexin beads actually, when a sperm sample is passed through this device, the annexin beads pull the fragmented DNA sperms towards it. So the normal DNA intact sperms are actually passed through the channel. So with all of these devices, it's enabling us to actually pick up better quality sperms, therefore get better quality embryos and help improve implantation. Now, when it comes to the man, we can't forget the various other procedures as well. But one thing which I wanted to highlight is, over the years, we have seen that, previously, when I was doing my fellowship, a Klinefelter was diagnosed, it was straight donor. You see maturation arrest, donor. In fact, now, even in our data of the micro teasers that we are doing, at least 30% of Klinefelters you're able to pick up sperms. So you're able to give that population their own genetic child. Maturation arrest. Now that doesn't mean that the whole test is there is absolutely no activity. So what we do under micro teaser is, with a trained eye and obviously with a microscope, you're actually looking at areas where you can actually see plump spermatic tubules. And these are the ones that are teased and we actually pick up sperms. And right now, we also have devices wherein we can freeze sperms singularly. See, though we are looking at millions of sperms being produced, not everybody does. So when we are actually doing micro teaser, we have devices in which we freeze a few sperms itself, just one, two, three, four, whatever is available. And that enables, again, this is one way of ensuring that you're doing the best in terms of the couple to get the genetic child. Now, we said that, obviously media is improving, the lab equipment is improving, the quality of your lab is improving. So, therefore, we are able to now culture embryos a little bit further. Why do we need to culture the embryos further? As you can see in this, as the oocyte is picked up, you see an M to oocyte, it goes through divisions. Previously, we used to do either a day 2 or a day 3 transfer based on the cleavage. We used to look at the quality and then do the transfers. We are not doing that anymore, at least most of the times. At Oasis, 95% of our transfers are blastocysts. Why did we move? We moved because obviously a blastocyst gives us a better quality of embryo as well as implantation. So rather than putting back 3 or 4 cleavage embryos, therefore increasing the chances of multiple pregnancy, what we are now doing is we are getting more information about the quality of the embryo. You leave it if that embryo has the capacity, if it has the nature of dividing well, it will become a blastocyst and it's easier for you to pick the right embryo for transfer. You're reducing your multiples and you're increasing implantation. When do we tend to do this? Most often we do it when people have multiple IVF failures and we don't have any other reasons to give them. We also use it to avoid multiple pregnancy. And blastocyst is the stage at which other procedures like PGT can be offered. When you look at this study, very clearly it tells you that the clinical pregnancy rates when you're doing a blastocyst transfer is way higher than what it would be if you do a day 3 transfer. Now, this is one of our favorite topics at Oasis. It's in vitro maturation. Now, in vitro maturation is a offset of IVF. Now, what do we do in IVF? We give them gonadotropic injections. We give them multiple injections. We take them through for at least about 8 to 12 days of daily injections. And we ensure that the follicles which start off in terms of their size being around 5 to 8 millimeters, we take them right up to around 18 to 20 millimeters. So you're going through a journey of multiple injections every day. Now, not that they have long-term impact, but still, it is not suitable for everybody. So in some women, what we do is, we don't actually give them injections for that long. We only give them between 2 to 3 gonadotropin injections, which is sometimes lesser than what you would give an IOI patient. Why? Because we don't want these follicles to cross 10 mm. We go and pick up these oocytes from follicles which are just 10 mm as opposed to a follicle which is above 18 millimeters. We pick up oocytes from these and obviously they will be immature. They then undergo maturity in the lab. So we have special medias through which we enable the immature oocytes to mature and then undergo ICSI and creation of the embryos. Why do we do it? It's obviously cost effective. It's more convenient. They don't need so many hospital visits. And the amount of emotional and the physical stress as well as financial stress is definitely lower. When do we do it? We do it for women who have PCOS. Why? Because obviously they are at high risk of OHSS. We also do it for patients for whom IVF stimulation hasn't worked. In terms of the quality of the oocytes, even with the best medications, they still have poor oocytes. Or if they have any history of thrombosis. Obviously, gonadotropins, high estrogen levels are not very safe for them. For them, we go ahead and do IVF. And also as a part of fertility preservation and hormone sensitive tumors. So if you have a woman with breast cancer and she's ERPR positive, obviously we wouldn't want her to be under the influence of gonadotropic injections and such high levels of estrogen. So for them also we consider doing IVF. So this is how an IVF is done. And as you can see in IVF, the first two, that is the GB and M1, are what are being aspirated, as opposed to an M2 oocyte, which is what gets aspirated in an IVF. So these GB and M1s are actually incubated, cultured in the lab with special medications, and then we do the ICSI once they mature. Finally, we come to this concept of pre-genetic testing. Now, this is something that we have been doing since, I think, 18, no, not even 18, I think it's been at least 8 years since we have been doing PGS. Now, why is it important and why are we doing it and how is it being done? Now, as you can see, we said that we have moved away from cleavage towards blastocyst. One of the advantages is we can offer women whose embryos become blastocysts to undergo PGT. What happens in PGT? Once a blastocyst develops, only the trophectoderm cells. So we are not actually touching the cells that actually become the fetus itself. We are only taking a biopsy from the trophectoderm, which in future will become the placenta for the pregnancy. So we are just taking a few cells, and these cells are then going to be tested for the whole chromosomal content. Previously, we used to end up doing only 5 or 7 chromosomes. Now, with the technology of NGS, we are able to do the complement of the whole 23 set of chromosomes. So that way, we are not missing out anything, and we are actually being able to completely rule out aneuploidy. Why is aneuploidy important? Obviously, if you put in an euploid embryo, a euploid blastocyst for transfer, your chances are going to be much better than just doing an untested embryo. When do we do PGT-A? Obviously, advanced maternal age. We know as a woman crosses 37, 38, the chances of aneuploidy are much higher. We do it for repeated implantation failures. They've undergone IVF, they've had blastocysts put back, but they still have not conceived. We said blastocyst gives them good implantations. We have done that, but they still haven't conceived. Then the next step is, even though they become blastocysts, you have to check to see whether they are euploid or not. So for repeated implantation failures, for recurrent early miscarriages. Again, when you have ruled out all other problems for miscarriages, uterine cavity is normal, both the parents' karyotyping is normal, thrombophilia screen is normal. They do not have any, endocrine problems, but they still have miscarriages. So in these unexplained recurrent miscarriages, we tend to do IVF, we create blastocysts, and then do the genetic screening in them. Obviously for severe male infertility as well. Now this is how a typical PGT report looks like. So here we actually sent approximately 5 biopsy samples. So 5 blastocysts were created and they were sent for analysis. And as you can see, we get a report like this, which tells you exactly which one has the normal genetic complement for us to go for a transfer. Previously, it used to be called as PGS and PGT. Now the nomenclature has changed. We call it PGT-A, which is pre-genetic testing for aneuploidy, like how I've just described. We also consider doing PGT-M, that is monogenic disorders like cystic fibrosis, or spinomuscular dystrophy. There are so many conditions for which, in the family, if there are some couples who have been affected, we need to break that chain. So when we are doing PGT-M, we actually test the embryos for those particular genes which cause the disease, and we eliminate those embryos and put back only the healthy embryos. Then you have PGT-SR, and this is for couples who have translocations. So what is the indications for PGT-M? Like I said, cystic fibrosis, Tay-Sachs, spinal muscular dystrophy, hemophilia, sickle cell disease, Duchenne's muscular dystrophy, thalassemia. Now these are the indications that we have done PGT-M for. Now we have done quite a bit of talk on the embryo, but obviously when we are talking about implantation, it's not just the embryo, it's also the endometrium. Only if you put a euploid embryo, pregnancy doesn't result. You have to have an endometrium which is receptive to the embryo that you're putting back. So this is where comes the concept of endometrial receptivity. Because we have seen that even though you put a euploid embryo, they may not conceive. At least a portion of them don't conceive. So that's when we have to ensure that they have a receptive endometrium. So what normally tends to happen is this. Around approximately 5 to 7 days post ovulation is when the embryo implants. This is, if you have a 28-day cycle, then around day 19 to day 25 is when the implantation tends to occur. Now, this is mathematically derived, correct? But this does not mean that every woman is going to follow that. In fact, 75% only follow that, and 25% tend to have a different kind of window of implantation. So when you have multiple failures, or when you have put back 2 or 3 blastocysts at different attempts and they still haven't conceived, that's when we tend to look at endometrial receptivity assay. Because here the window of implantation tends to change. And in fact, what we tend to do is we work up the woman like how you're going to go ahead and do a frozen embryo transfer. And we take biopsies at the approximate time that we are going to be doing the transfer. So suppose we are doing a blastocyst transfer. From the start of progesterone, 6 days later, we put the blastocyst. So instead of putting a blastocyst on the 6th day, we take a biopsy of the endometrium and we assess it. What are we assessing? Genes. We are assessing about 238 genes in that sample to see whether it is showing or it is actually showing the markers for all of those 238. If it doesn't, they at least give you a report like this, which tells you that the time that you're supposed to be doing the transfer, whether it falls into the receptive window or whether it is pre-receptive or post-receptive. So this enables you to actually decide on when you want to do the transfer. Should you predate it or should you postdate it? So information like this obviously is very helpful because then you can actually put an embryo at the time that the endometrium is more receptive to it. So when we are putting a blastocyst, and this is for women who are less than 35 to 37, you get a pregnancy rate of 45 to 50%. If you add on pre-genetic screening for this, then you can up your pregnancy rates to 60 to 65. If you do genetic screening with endometrial receptivity assay, you're going up to between 65 to 70%. So over the years, we have actually progressed to come up to this stage. We still haven't reached a 100%, so that's the first thing we always tell our couples. There are no guarantees, obviously, in fertility treatments, but we have to tailor the treatment to what the couple actually needs. The most important aspect over the years that we should not forget and which we should promote very actively is fertility preservation. Because over the years, what we have seen is that, with economic stability, women seem to be postponing their childbearing age. We have more women coming in their mid-30s and late 30s than what we used to before. So that's when we have to talk to them about social freezing. In fact, there are some companies like Facebook and Apple who have given the insurance to their women who are working with them to say that instead of actually waiting, let them go freeze. They are actually giving them the financial support for freezing their oocytes so that then later they can go ahead and conceive. Now, age is obviously very important in fertility. If there is one factor that we have to pick up, it's not her BMI, it is not about the male factor, nothing else. If there's only one factor that you have to pick up, not even AMH, it is age. Age is one thing that has a great impact on your success rates. And that, therefore, any woman who is not likely to conceive or doesn't plan to conceive, before 35, then this is something that should be offered to them. Offering fertility preservation for social freezing after 35, obviously, your results are coming down. So we have to address this quickly. Now, the reason why fertility preservation has taken such a strong hold is because of this technique, which is vitrification. Now, with vitrification, we are actually able to come up to almost close to 100% viability of the gametes. So let it be egg, let it be sperm, let it be testicular tissue. We are able to actually bring it back with the thawing process, with the freezing as well as the thawing process without having any kind of casualties. And this is the reason why fertility preservation should be discussed. In fact, when we are really looking at ASRM, there is a very strict guideline which says that oncologists have to speak to the reproductive age people about freezing their gametes before they go for any kind of gonadotoxic therapies. Let it be chemotherapy, let it be radiotherapy or surgical options. We should be discussing with them about if it's a woman freezing her eggs, if it's a married woman freezing her embryos, and if it's a man freezing his sperm. This is extremely important because in the future, if we don't do that and later on they become, infertile, they might as well go ahead and sue us for not giving them the options. And when it is so simple right now to do it, it seems a shame not to utilize the facilities. So in women, prior to chemotherapy, radiations for any kind of cancer, leukemias, lymphomas, before they go for any kind of autoimmune conditions and treatment for it. One thing which also has been added recently as the indications for fertility preservation is young girls for whom we see severe endometriosis. How much ever you give them Dynogest, how much ever you give them the pill, whatever you do, it's only for that period of time. Endometriosis is a progressive condition and we're seeing so much of it. So this has to be discussed even if it is a woman, adolescent girl or in their early 20s. Because they shouldn't get to a point wherein we will not be able to utilize their own gametes. So the take-home message today, fertility treatments have progressed in a long way. Improved success rates with advancements. Research is still on in terms of improving our success rates, particularly in selecting an embryo, stem cell therapy for low ovarian reserve and or endometrium, and obviously techniques to improve implantation. Like I said, we have come up to approximately 60 to 65% take-home baby rate, but we still need to go further. And that's where research is going on. So the best is yet to come in our field. Thank you very much.
Thank you so much, Durga ma'am. It was a very, very informative session. So, shall we take the questions at the end of the panel discussion? Shall we move on to the panel discussion now? So now we move ahead with the panel discussion. I'll be taking the privilege of moderating the panel discussion on some challenging cases in infertility. It's called clearing the clutter. I call upon Dr. Durga Rao to come and occupy the seat. And Madam requires no introduction. So she is the brain box in infertility. She is highly tactful in dealing with very complicated cases and making the couple's dream come true. Next, I call upon Dr. Krishna Chaitanya. He has an overall experience of 15 years, an expert in clinical embryology and cryopreservation of gametes and embryos, apart from extensive knowledge in the latest ART. He's passionate about human embryology and constantly researches on innovative approaches to improve the success rates of IVF treatment. The main areas of work are cryobiology, in vitro maturation of oocytes, embryonic stem cells, andrology, and men's health. He's also working on employing newer techniques to improve the success rate of IVF in PCOS and to prevent IVF failures. Dr. Krishna studied and practiced in Australia. He also undertakes collaborative research work with the Department of Reproductive Biology, Monash Institute of Medical Research, Australia. He is also the Indian Ambassador for Academic Affairs, Department of Reproduction and Early Human Development, Monash Institute of Medical Research, Australia. So this is myself. Next I call Dr. Joylyn G. Almeida. She's a consultant obstetrician and gynecologist and a laparoscopy surgeon with specialization in high-risk pregnancy, adolescent gynecology, and preventive gynecology. I call upon Dr. Vatsala Kamath, my beloved teacher, and she has over 28 years of experience in her field. She is a professor and unit chief in the Department of OBG in AG Institute of Medical Science and Research Center. She is a faculty and examiner for MBBS and MS. She is a consultant obstetrician, gynecologist, and laparoscopy surgeon. She was a past president of MOF and at present vice president of AMC. And she is the chairperson for PCP&DT Committee of Dakshin Kannada. And I call upon Dr. Gaurav Mitchell. He's the backbone behind me. And he's our chief clinical embryologist at Oasis Fertility, Mangalore. He has done his MBBS from JNMC Varda, graduate diploma in reproductive science and masters in clinical embryology from Monash University, Australia. His interests lie in research in embryology and contributed to a few papers internationally. Okay, now the theme is clear the clutter. We have got some mind-boggling case scenarios from Oasis Fertility. Case 1, this is Mrs. A, 36 years old. The husband is 37 years old. They are married for 8 years and they are facing primary infertility. She is a known case of PCOS with irregular cycles. It was 4 to 5 days initially, once in 3 months. Once in 2 to 3 months, and later on, in the past 2 years, her cycles have come down to 3 to 4 days, and once in 1 to 1.5 months. And ultrasound shows PCO morphology. She didn't have any evidence of clinical or biochemical hyperandrogenemia. She is overweight, BMI being 28.7, so no significant past medical, family, or personal history. Coming to the male partner, he is 37-year-old businessman, occasional alcoholic, non-smoker. He doesn't have any medical or surgical illness, no significant family history. But his semen analysis showing total count of 10 million with 20% motility. He was given multiple courses of antibiotics and antioxidants. So investigation of the female partner shows FSH is 7.7, LH 4.28, AMH 7.44, vitamin D 22.4. So coming to her previous treatment history, she underwent multiple cycles of ovulation induction with time intercourse with oral agents as well as gonadotropins in multiple clinics for over 4 years. She underwent 2 cycles of IUI at a private hospital where she was given letrozole for 5 days and urinary gonadotropins for 2 to 3 days. Ovulation was documented, endometrial thickness and pattern were optimum as per scan, and no details on semen. So it's now been 7 years since she has started the treatment. So you see the clock is ticking here. She then underwent hysterolaparoscopy and ovarian drilling, and that at the age of 35. Her tubes were patent, and rest of the abdomen, pelvis, and uterine cavity was normal. Let's relook into what's happening here. Is laparoscopy ovarian drilling justified? Madam, Dr. Vasila Kamath.
Yes, so now there are different views on the subject, but according to the international guidelines that have come out in 2018 for PCOS, especially in patients who are infertile and anovulatory, it has been suggested that you can try ovarian drilling in clomiphene resistant patients. Another indication would be if you're already doing laparoscopy for some other indication, you can give it as an adjunct ovarian drilling. Another is, of course, as an alternative to GnRH therapy, because I think that happens in practice, that a patient is staying far away and she can't come every day for the intensive monitoring that is required for GnRH therapy. In such cases, but most important, I would say that we have to counsel the patients about the risks and benefits of such surgical treatment. That's of the utmost importance. And if both are on the same page and you go ahead with it, you can use the needed electrode and to reduce the damage, unnecessary damage to the ovarian tissue. You can follow the rule of 4, it's called. That means 4 punctures in each ovary, 5 seconds, 40 watts, 2 to 4 millimeters. And then you can, after this, you can do copious irrigation with normal saline so as to reduce periadnexal adhesions later. There is some role for this, and I think there are different views also on this.
Thank you, ma'am. But in this case, do you think it was justified?
It depends, like you're saying, no, they go to different clinics, each one has their own advice for the patient, and then what she decides. And after this, the patient, I think, because of the laparoscopic ovarian drilling, the ovaries become more sensitive to the ovulation induction agents. So they must have tried again some more ovulation induction agents and IUI. And then I think next she should go for IVF. I think that would have been your advice,
Yes,
probably.
ma'am. Absolutely right. So it's not first line. It's only used for whatever madam has told. I'm just summarizing that. So it's mainly used for CC resistant case, and especially when the LH is high and normal BMI, and when it's difficult to monitor, like when she's from far off place, and of course while doing pelvic laparoscopy for some other pathology like endometriosis, etc. Okay, and of course, follow the rule of 4. So what it does, it reduces the reserve and post-op adhesions are very high post-op adhesions, and of course anesthesia complications and infections. It can reduce the live birth when compared to ovulation induction alone. There is no much data saying that laparoscopic ovarian drilling really matters a lot. There are studies saying that it reduces the live birth, in fact. So, what are the advantages? The advantages are it reduces the OHSS, and of course, it reduces multiple births. Now, coming to role of vitamin D in PCOS patient, Dr. Joylin.
So the role of vitamin D in PCO is highly controversial. There are numerous studies that advocate the use of vitamin D as well as against it. But essentially, when we see physiology, vitamin D is responsible for things like follicular maturation, EMN signaling, the levels of exercise which are required for follicular development, etc. So that being said, the studies have demonstrated that almost in a patient who is known to have PCO, 65% of patients do have vitamin D deficiency. So we use this data for retrospective confirmation for treatment with vitamin D. Vitamin D levels, low levels are associated with increased insulin resistance also, and very good connection with that and infertility, things like
anovulation, and also cardiovascular disease, etc. So low levels of vitamin D are known to be associated with patients with PCO and also with patients who have prolonged infertility and insulin resistance. So that being said, as a pre-treatment for patients who are going to undergo any kind of infertility management, vitamin D is definitely indicated. It's also known and studies have proven that vitamin D and calcium supplementation along with metformin increases the results in stimulation protocols that are used for patients with insulin resistance. So definitely worth trying without too much of a loss.
Yes, thank you, doctor. So, as Dr. rightly pointed, so vitamin D plays a physiological role in reproduction. How it helps in follicular development and luteinization. It reduces the AMH signaling. In fact, the patients with high AMH usually it lowers the AMH level, and it increases the follicle stimulating hormone sensitivity. It increases progesterone production in human granular cells. It also affects glucose homeostasis. And as Dr. Johnny rightly pointed, the patients when they have low vitamin D levels, it exacerbates the symptoms of PCOS, especially the metabolic syndrome. And insulin resistance, ovulating menstrual irregularities, high infertility, hyperandrogenism, obesity, and it also elevates the risk of cardiovascular disease. The same case, she then underwent 2 more cycles of IUI with ovulation induction and gonadotropin. Ovulation was documented in each IUI, and semen post-process was 12 to 14 million with total motility of 60 to 70%. So, what we could have done differently, Durga ma'am?
I think since she's had quite a long journey, so in my view, I think the first thing that we should have done is for obesity. I think we need to address lifestyle management first before we even consider going ahead with further treatments because she's already 35. That's the second thing that we have to keep in mind. So I don't think we could have done anything differently except for lifestyle management and looking at her reducing her BMI, putting her on a metformin because obviously there are evidence of insulin resistance, and after 2 cycles of IUI, I would now take her towards IVF. But I wouldn't find anything wrong with her trying 2 cycles of IUI, having had ovarian diabetes already done. But going beyond this, I don't think would be sensible.
Thank you, ma'am. So, elderly PCOS. Are they just like any other PCOS, ma'am? Vasudha ma'am?
As we know, elderly PCOS, their decline in ovarian reserve is less than in PCOS patients. But having said that again, their oocyte quality might be poor, and that might give rise to more failure rates with even your IVF. Also, many of these patients, especially our patient, I think 36 years overweight, she might be already having metabolic syndrome. So this also complicates matters further. So before she proceeds further, like Dr. Durga rightly said, we have to address these issues, lifestyle modification, etc. And then even when she becomes pregnant, there's more chance of miscarriage, then there's more chance of hypertension, diabetes, chromosomal problems, etc., or anomalies, etc. So this initially, I think the most important is to get her back in shape and then go ahead with this and look for all these disorders even before she becomes before she starts further treatment. And then during pregnancy, strict surveillance again is necessary for all these problems. And then hopefully with all this optimum management, she should have a happy ending for her in terms of fertility.
Thank you, ma'am. So, elderly PCOS, though they say that the fertility is better than when compared to younger PCOS, we have to always keep in mind about the other risks like they are more prone for metabolic syndrome, diabetes, etc. And also the chromosomal anomalies in aging oocytes. So that we have to keep in our mind. So do PCOS have all the time in the world because their AMH is on the higher side? Durga ma'am?
Like Madam has always said, I think age obviously is something that we don't have any control and any kind of a treatment for. So even though she does have PCOS, I would still, like I keep harping about, age seems to be more of a factor that we have to consider when we are looking at, making a management plan for her. So even though she does have PCOS, I would still say that we have to go towards IVF having had 3 to 4 IVF failures.
What can you expect when you stimulate her? Dr. Joylin?
So in an elderly PCO, papers have shown that they can have something called a sustained fertility. Where when we do an AMH, very often we can find that they have a really high AMH, maybe a lot of follicles, so very good antral follicular count. But like Madam already mentioned, the quality of the follicles is what matters to us. So there could be situations where if they have a decent number of good antral follicles, then probably with a regular dose of the stimulant they will respond. But most often what happens is a lot of small follicles develop and the quality of those are not really good. So a very high dose of a stimulant, if it's an ovulation induction agent or gonadotropins is required, a very high dose. And simultaneously the problems of OHSS have to be tackled along with that.
Yes, thank you, doctor. So her course with us, she got metformin 1 gram and antioxidants like CoQ treatment for 6 weeks. Then we used antagonist protocol. She was given growth hormone, and the trigger was with the dual trigger. We got 16 were expected. We could retrieve 18, and 13 were mature M2, 13 fertilized, and 4 day 5 embryos, and 2 day 6 embryos were frozen. And for semen, microfluidics was done on fresh ejaculate. She underwent a down-regulated FET cycle, and day 5, 2 day 5 embryo or blastocyst was transferred, and she was beta positive. Her value was 549. Now, what is the role of growth hormone in PCOS? Durga ma'am?
I think a very limited role of growth hormone in PCOS because again, growth hormone is not something that has been validated by the FDA. So we have to be very careful in whom we are using growth hormone. But in the situation of a PCOS, if she's resistant to even gonadotropins in the sense that the sensitivity of the follicles to FSH is low, there could be some kind of polymorphism which is causing the sensitivity to be low. In these women, giving them a pre-treatment of growth hormone or growth hormone with gonadotropins would actually help in reducing the duration of the stimulation as well as the dose of the gonadotropins and makes the follicle more sensitive to the gonadotropins that we're giving it. So the role of growth hormone is for people who have shown low sensitivity to your stimulation protocols.
Thank you, ma'am. So growth hormone is controversial. The thing is, it will mainly reduce the oxidative stress and it will improve the mitochondrial function of granulosa cells. It might improve the oocyte parity in ladies with PCOS, and as ma'am has told, it will augment the action of gonadotropin. Therefore, we can expect some slight improvement in folliculogenesis, in fact, steroidogenesis and folliculogenesis. So it can be given in patients with poor ovarian reserve, PCOS, and elderly patients. Any other investigation we should have done? Salama?
Like we said, this patient is already 36 years, she is overweight. So she already might be having risk factors for cardiovascular disease. So definitely the fasting lipid profile should be done and also the OGTT, and if not that, at least a fasting blood sugar and the glycosylated hemoglobin. Again, as Dr. Durga and I have been continuously saying, the lifestyle modification is most important for her. And if you find anything abnormal in these tests, definitely she should have a physician reference also, so that ultimately what we want is to conceive and have a baby at the end of the day.
Thank you, ma'am. So we can, as Madam rightly said, a lipid profile should be done, And also we can do HOMA-IR or insulin resistance index, because we can pick up these patients at the earliest. Even if the HbA1c and SBS might be normal, but insulin resistance may be high, we can push them for proper lifestyle modification. So any particular pre-treatment, Dr. Claudia?
For this particular patient in elderly PCOS, metformin is something that is definitely recommended again to bring down the insulin resistance, improve the fertility outcome, and also continue into the pregnancy and improve the pregnancy outcomes as well. Also, response to the gonadotropins and stimulation protocols is much more when the patient is on metformin. So, metformin is one pre-treatment which is highly recommended. Another thing, certain studies have shown also maybe if she has irregular cycles, probably 2 or 3 cycles of OC pills to reschedule the follicular development is something that is suggested. But I would like to know what Dr. Dulka ma'am thinks about this particular thing.
Uh, Pill somehow always suppresses the response to the gonadotropin. So when somebody is been taking the pill, particularly if she's taken it for longer than a month, we tend to have longer duration of stimulation and more gonadotropins being used. So unless it is absolutely required, we don't tend to actually downregulate them with the pill at all. The only thing is if they have asynchronicity at the follicle and the start of the stimulation, you might probably give them an antagonist or just a simple estrogen pills for approximately 7 to 10 days. That tends to synchronize the follicles and also helps in terms of getting you a better outcome. But pill is not something that we are very favorable with.
Also, treatments with corticosteroids, myonisodol, lot of talk around that. Certain centers, certain protocols allow it or want it, some do not. What would
So,
your view
like
on that?
we give metformin to reduce your risk of OHSS, to reduce your risk of resistance, again, definitely steroids can be given, but duration of the stimulation as well. But again, steroids would be justified if their androgen profile is abnormal. So in those people, and particularly with a history of any kind of resistance, yes, during the stimulation,
Individualize the protocol for
Cover.
steroid and pre-treatment based on the patient and not just
it's not pre-treatment, it would be given during stimulation. Pre-treatment is only metformin. Lifestyle management,
myonisodol also.
myoinositol, the evidence is mounting. So I think, slowly we are getting converted.
Information microfluidics is a newer way of sperm selection. I think there's so much that for the last 15-20 minutes, my colleagues have been talking about what's being done to the female side. And it so happens that when it comes to male, we only just want a semen sample, ICSI, and the story ends there. I think that's where the whole focus is changing. At least in the last decade, there's been a lot of focus on male factor infertility. How do we optimize the outcome from a male perspective? And that's where the focus is on optimizing sperm selection. So microfluidics is one such technique, as you can see in this video, where there are micro channels and you put the semen sample and the sperm with good DNA quality gets channelized, good morphology also gets channelized, and then you can pick them up. So it does help in picking up the best quality sperms, and that would in turn help us have an optimal outcome. But again, is it a thumb rule? Is it something that we could advise to every patient? Probably there isn't enough evidence to say it should be a routine practice. So right now, for men with raised sperm DNA fragmentation, so somebody with that prolonged history and multiple failed IUIs, I might have probably got a sperm DNA testing done, and only if the value was raised, I would have probably recommended doing a microfluidic method of sperm selection. But it did help, look like. So we've got good blastocysts, and the lady was pregnant. So the focus on sperm selection is something that I would want to reiterate, and microfluidics is one of the methods that can help in optimizing sperm selection.
Thank you.
Doug, you wanted to add something?
Continuing with that, since the DFI value was kind of borderline, it was somewhere around 24-25%. Do you think microfluidics should be the first method to treat sperm DFI? Like you rightly said, there are other techniques as well. So
Yeah.
what else would you
So I think that is the answer that's still not answered. So of the the other methods, there's something called as MAX, which is a magnetic activated cell sorting. Immunology people have been using for a long time now. I think we've applied it to the sperm. So again, it helps us picking sperms with good DNA. There's something called as physiological ICSI, where sperm bind to hyaluron embedded drops, and finally IMSI, which Dr. Durga spoke about, which is picking up sperm at a very high magnification. I think these are the 4 commercially available products for sperm selection right now. Which one's superior or inferior? Though there have been some RCTs comparing them, who still don't have the answer, which one is the best. But microfluidics in specific has an advantage. The 2 advantages. One, the sample that's finally prepared, whatever we collect from the channel, and IUI is also possible. It's just not that we should only do ICSI. Because IMSI and PIXI, the insemination will only be a ICSI method. But with a microfluidics chip, an IUI is also possible. That's one advantage. Second advantage is that even if we have got lesser sperm counts of 2 or 5 million with a 5 or 10% mortality, microfluidics will still separate the sperms. There is recovery and ICSI is possible. The other methods, if anything is less than 5 million, it is not applicable. That is IMSI, PIXI or MAX. For a very severe OATS or severe male factor infertility. Right now, microfluidics seems to be helping us optimize sperm selection. So we don't have an answer as to which is the best method. Microfluidics seems to be giving good results, but we need to wait for more RCTs and meta-analysis to come up.
So just to add on to that, I think from our lab's perspective, it's quite an easy procedure to do, and it's automating one technique. So if going towards future, if we're looking at complete automation of the lab, I think.
Yeah, this is one of the steps to automate the process. Less human intervention here, but I think we need to wait. Is it a treatment for everyone for every IVF cycle? Probably the answer is no at this point.
The next question is also to you only, Dr. Krishnas, because you are a very good embryologist as well as embryologist. So, how will you evaluate the male side for the recurrent implantation failure, Dr. Krishna?
Recurrent implantation failure. All right. So again, currently in ART practice, along with the female partner, we should be encouraging the male partner to also come. A detailed history examination is a must. Just asking the wife to tell husband to get a semen analysis done is not taken. I think involvement of the male partner right from day one is important. I think that's where it should start. And based on semen analysis, we'll do the workup. Now that the question isn't specific to a recurrent implantation failure, where we only want to do laparoscopy, hysteroscopy, and so much more at the female side. In the man, apart from the semen analysis, there are certain tests that we can do. One is getting the sperm DNA fragmentation test. We all agree that a semen analysis is still the gold standard, a good point to start off with, but it isn't a very, very validated test which can predict the pregnancy outcome. Now, just based on the semen parameters, we cannot be predicting whether this lady will be successful with a OITI cycle, IUI, IVF or ICSI cycle. that kind of a prediction for pregnancy is not possible based on a WHO's criteria of semen analysis. So that is where there's been need of some functional tests. So sperm DNA fragmentation, of the years of decades of it, experiments and research that's happened, sperm DNA fragmentation testing seems to be helping us prognosticate the reproductive outcomes to an extent. So we can test. So where do we test? Recurrent implantation is one such indication. Recurrent pregnancy loss is another indication. So for whenever you see a couple with RIF, you probably can from the male side get a sperm DNA testing. There is evidence to say that also get the genetic evaluation. If the sperm counts are more than 5 million, we'll only get a karyotyping done because there are chances of having some kind of a numerical or structural disorders on a karyotype that we pick up. Or if your sperm count is less than 5 million, then probably we are going to get karyotyping and also Y chromosome deletion. So for RIF, DFI, karyotyping, and if your counts are less than 5 million, I might want to get a Y chromosome microdeletion test.
So, summary of this case, she's an elderly PCO, treat with little more caution, and protocols definitely should be individualized. It should be an OHSS-free victim, and treat the patient as a whole, and main parameters should be monitored, it should not be overlooked. Now we have got case 2. She is a 39-year-old lady, husband is 41 years, 12 years of married life with regular cycles, hypothyroid and thyronorm, and she had 2 ectopics. The first time laparotomy was done and salpingectomy, and second laparoscopic salpingectomy. She had 4 IVF cycles and 8 transfers in total, and she conceived in the second IVF. She conceived a DCDA twin, and first at 8 weeks there was a fetal demise, and the other aborted at the 5th month. So she conceived in the 5th transfer, second IVF, 5th transfer. A query of cervical incompetence was, but then she had also history of thin endometrium during the transplant. So husband semen analysis showing severe 3 million per ml with 10% motility. Dr. Krishna had already answered this. So I would like to ask this question to Durga ma'am. Ma'am, how should we evaluate an RIF case?
I think the first thing is, like Dr. Krishna said, a complete history and evaluation of all parameters has to be done. When we are looking at recurrent implantation failures, we need to start from the basics. That is, we need to evaluate the uterus to ensure that the cavity is normal and there are no intracavitary lesions. Even though we are doing IVF, it's very important for us to also look at tubal pathology and to rule out any hydrocephalus. Then comes the workup in terms of any hormonal or endocrinal problems that hasn't been evaluated in terms of their thyroid, in terms of their prolactin, whether they are, whether their HbA1c is normal. Once that is done, though the evidence is scant in terms of thrombophilia screening, that could be one of the things that we should be looking at, because she's already got a second trimester miscarriage, a 5th month of miscarriage. So we would be looking at a thrombophilia screening as well. And we need to do a karyotyping of both the couple to understand that there is no, structural rearrangements of the karyotype. And, as part of the male infertility workup, we have to be looking at the DNA fragmentation index of the sperm. Once that is done, that's when we would actually say that we would go for another IVF cycle, provided that she has enough ovarian reserve, go to a blastocyst culture and consider doing genetic screening of the embryos. I don't think she needs any endometrial evaluation in terms of receptivity, because she's had 2 implantations. So I don't think there's a problem there in terms of the receptivity, but yes, we should be looking at doing genetic screening of her embryos. Particularly, she's 39 now, so I think, another reason why we should be looking at aneuploidy.
Thank you, ma'am. So her RPL profile, protein S was decreased, beta-2-glycoprotein positive. Hysteroscopy was done, adhesions were present on all walls, bilateral ostia not visualized, and her CD138 this positive, chirurgical doxy and metrogen. 6 months later, a relook hysteroscopy was done with PRP installation, adhesions at lateral walls, bilateral osteoid not seen, property iodine inserted, and augmentin and minocycline was given. She was CD138, that is for chronic endometritis, negative. The marker for chronic endometritis was negative. Now, histoscopy reveals hidden secrets. Dr. Joining, do you agree or not?
Histoscopy very often reveals a lot, and it is known that a lot of patients who are normal or an HSG or an ultrasound, almost around 35 to 40% of patients who have a normal HSG or an ultrasound do reveal findings on an office histoscopy or a diagnostic histoscopy. So the internal architecture in terms of whether the implantation will happen or conception will happen or not gets a lot of information for an histoscopy. Is definitely indicated.
Yes, especially in additions, which can't be picked up by 3D. Then rest of the things might be picked up, but additions are highly specific. I mean, plus we can see what type of endometrium it is. So histoscopy is definitely way better than any other modalities. So should it be done for everyone before IVF, ma'am, Durga ma'am?
Not for everyone, because nowadays I think with three-dimensional ultrasound, particularly if SIS is done with three-dimensional, you're able to actually get quite a bit of an information about the intracavitary lesions. So it need not be done for everybody going for IVF. But definitely, if you have somebody with recurrent implantation failures or even a miscarriage, then I think we would be looking at doing a hysteroscopy. And particularly if you have a young woman with male factor and you're doing IVF for that, again, hysteroscopy is not mandatory, provided you have some kind of evaluation being done in terms of a 3D ultrasound.
Right, ma'am.
Ma'am, this patient, Vasana ma'am, this patient, she aborted the second twin at 5th month, so there was a query of cervical incompetence. So, do you think that we should put cervical stitch for every IVF conceived twins?
No, I don't think you should put a cervical circlage for every IVF conceived twin. In fact, there are definite guidelines by the FIGO which says that for whom you have to put the stitch, and that's all history, either say history indicator circlage or an ultrasound indicator circlage. Now in this patient, but she's had a second trimester miscarriage, and probably you can, after the AT scan, you can do the cervical length, and if it's reducing or if it's short, probably you can think of putting a cervical. But how much is going to help, we don't know, because as we see, there are multiple factors for her which might give rise to a poor obstetric outcome. So we have to give a very balanced this thing about putting a stitch for her.
Yes, ma'am. And studies have shown that prophylactic cervical encirclage is not indicated, and in some cases, of course, rescue cerclage do help. So this patient, IVF cycle with dual stim was done. It was an anti protocol, and oocyte quality was very poor oocyte quality with large PVS with septa, fragmented polar body, and TISA was done around one sperm in 15 high field was seen. Two embryos we got two embryos. It was subjected to PGTA and ploidy, and we got one normal. So with previous many failed cycles, it was decided to go for an ERA before transferring the single normal blastocyst. ERA with HRT was found to be receptive at 123 plus or minus 3 hours after progesterone administration. Patient underwent FHE, and as per ERA guidance, and beta HCG was positive. Now, does TISA play a role in case of recurrent implantation failure? Dr. Gowler?
Video.
So, ma'am, it depends. Like Sir very clearly said that if the patient's undergone sperm DFI testing, and
Yes.
we've seen a very worrying picture if the sperm DFI is, say, at 50% 40% or 45%, 50%. Uh, all the methods to tackle sperm DFI don't really work beyond the limit. So max microfluidics, physiological ICSI, MC, they have their limitations. So if the sperm DFI has increased to a level that is beyond repairable by any of these methods, I think TISA does have a role to play. But then again, it is a surgical intervention, and like any other surgical intervention, it has its own risks. So such patients need to be counseled appropriately, and only then a decision about this has to be made. I think, sir, would
Yeah, I agree with Gaurav, and why that question is there have been studies and groups who have considered doing testicular sperm aspiration because this guy had a 3 million sperm count with a 10% mortality. So there are some group of people, especially the Cornell group in USA, they have straight away advised TISA. They've tried doing TISA because their concept is at the testicular level they are just produced. The amount of DNA fragmentation is lesser. That's a proven fact. So they say in such people with recurrent failures, just go get the testicular sperm and do ICSIs. So there have been anecdotal results where it has really worked well, but again, now over a decade, meta-analysis are saying that only if you have a proven value of DNA fragmentation that's raised, you might want to look at doing TISA. But again, with person with one failed IVF, the next cycle will be as a blanket therapy to a TISA, not proven to be beneficial at this point.
Thank you, sir. So in this case, we have done PGTA-A. So Durga ma'am, what is the relevance of PGTA in this case?
I think the indication are two for this couple. One is the fact that she's 39, and the second is she's had, I think, if I remember right, at least 8 embryo transfers and are not progressing.
4 IVFs and
13 embryo transfers. So, these would be the two indications that would suggest that she needs PGTA. And particularly, with a history of a miscarriage, even in the second trimester, I think FDA have ruled out all other reasons for recurrent miscarriages, then that would be the other reason for us to do PGTA.
Thank you, ma'am. Ma'am, any benefit of endometrial receptors in this scenario?
Frankly, like I said, she's had 2 transfers which resulted in implantation. One was a miscarriage at 6th or 8th week, and one was at the 20th week. So, frankly, it does say that the endometrium is receptive. At least of the 8 transfers, 2 transfers she did conceive. So, I'm not very sure about the benefit of ERA. And frankly, that does prove by saying that when you've done an ERA, the receptivity was at 123, which is exactly at the point of doing, the window of implantation hasn't changed. So I think there was really no reason for us to do ERA in this particular situation.
Thank you, ma'am. So I know it's getting very late. This is the next case is very short and sweet. So it's mainly on male infertility. So Dr. Krishna and Dr. Gaurav will be talking a lot about this case. We have got Mrs. X, 30 years old. Her male partner, 32 years. They are married since 4 years, and case of primary infertility. Female parameter absolutely normal. Husband reported azoospermia on 2 occasions from different labs. Had no significant past personal or family history. Dr. Krishna, how will you proceed?
So, no offense, but an azoospermia person, there's a lot that can happen by a gynecologist in terms of management. The role of a urologist when there's azoospermia is very minimal, and it's only when you need a surgical intervention. It's either you want to do a surgical sperm retrieval or a varicocectomy if indicated. Rest everything, I think the gynecologist or the ART specialist can deal it. The moment we see azoospermia, I'm sure in busy OPD day you see a report, you'll be like, refer to urologist. I don't want to spend time counseling the male partner about the prognosis and all of that, but trust me, it makes a lot more sense in terms of building up the confidence of a couple because they want everything under one roof. You're dealing the female and you know what's happening, how much of timelines you've got, what is the prognosis of this case. So referring to a urologist, they are not going to sit and do any kind of counseling. And we all know that there's very limited role for medical management. So I think there's so much more that you can do. So how do I proceed? In the case of azoospermia, without two semen analysis done, ideally it should be a 6 to 8 weeks of gap between two semen analysis. And at least if the first sample is azoospermia, the second time when the lab is again doing a semen analysis, a specific instruction to centrifuge the sample is very important. Because we're only putting one drop, which is 20 microliter of semen, and we don't see anything reporting azoospermia might not be right. The ejaculate volume is 1.5 or 3 ml at times or more. So we would want it to be centrifuged. You look at the pellet completely, you don't see sperm, then only the diagnosis of azoospermia should be made. And if you see even 2 or 3 sperms, the inference is cryptozoospermia and not azoospermia. So that's number one. And while you're repeating a semen analysis, it's advisable to get a post-ejaculate urine so that you can rule out retrograde ejaculation. That's another precaution. That's why when you're writing the instructions, it's important to give these instructions. And that is why interpreting the semen analysis report is very important. Because, just looking at the impression is not going to sometimes give us a lot of information. If I have a report of azoospermia, but the ejaculate volume is only 0.3, now there's a suspicion if the sample was collected properly or was there a spillage. Because the moment you say azoospermia, I'm sure these patients are sitting and Googling it and they really get very stressed. So reading in between the lines is important, and if it is a simple thing like there was a spillage or it was not properly collected, or sometimes it's just the prostatic fluid that's produced. So repeat semen analysis with, if the patient is not comfortable in the clinic, you do encourage them to go get a home collected sample with certain precautions, of course. So you do all of these things, interpret, make sure that the diagnosis is azoospermia. Once you have 2 reports which are azoospermia, I'm assuming a proper history and examination is done because that's going to give you a lot of information as to what the story hereafter is going to be like. Especially in the examination, if we have seen very low testicular volume with azoospermia, we know that this probably is going towards non-obstructive azoospermia. So the hormones, what we are going to getting done here, will just add further to it. Azoospermia with very low testicular volume, we know it's non-obstructive azoospermia. There's very minimal role for medical management. We would probably do a testicular sperm aspiration. You get sperm, it's ICSI. You don't get sperm, based on histopathology, you'll have to plan it further. So history, examination. Female gynecologist, we don't want to examine the male. I think that's not how it is to be looked at. I think male evaluation intervention is a part of the ART practice. So I keep having little lighter moments with our students. They also have this tendency, the moment they see a male patient or something that goes wrong, they'll run to me and they'll come and they just want me to intervene. Then I just turn to them and say, FRM is not female reproductive medicine specialty. It is fellowship in reproductive medicine. And male is a part of it. I keep underlining that. So examination of the male will give a lot of information. So I think examine and see, and then probably we should go ahead with the investigations and management there. So Gaurav, you could add a bit on.
Yeah, I think bang on, and I think the fructose test is also another option that we could have taken. If the fructose test comes back positive, we know for a fact that there is some sperm.
Or at least it's not obstructive.
It's not.
So because fructose is a marker of seminal vesicle, and if that's positive, that means the seminal vesicle is functional. and you've at least ruled one component in the reproductive tract, and you've to an extent ruled out the obstruction.
Thank you, sir. So, will you advise testicular biopsy, Dr. Gauda?
Like sir just said that proper investigations, proper history taking is paramount to such a case. I think if we find sperm on centrifugation, testicular biopsy can be an option wherein we can find sperm and freeze some motile sperms like Durga ma'am just spoke about. There's a device called sperm vitrification device that allows us to freeze 10 to 15 good quality sperms in a device. So yes, it can be a possible option. But
Just to add on, so okay, before we go to the biopsy there, just to summarize, I'm sure we all are waiting for the dinner to be served. Let's keep the workup. It's easy. It's not very complicated. Examination. If you're seeing things that are positive towards non-obstructive asus program, what is that? A low testicular volume, presence of a vas, and is there any other sign of testicular deficiency? The pubic hair is sparse or the tanners is not 5 in this man. All of this is indicating non-obstructive asus problem. You have a normal testicular volume, you're not able to palpate the vas, then probably it's obstruction. Then, the investigations is hormones, total Doppler, truss, genetics. There will be 4 of them. So you will have to interpret. Just don't give the investigation list and say everything is normal. I think you need to connect the story to the male partner because they're getting anxious. So get the hormones done and see what it is saying. Again, it can't 100% predict whether you're going to have the retrieval or not. Genetics, we spoke about it, karyotyping, Y chromosome. CFTR screening only if the vas is absent or you've done a truss and the seminal vesicle is absent. Then only we're getting it. You can't say normal testicular volume, all hormones are normal. Probably this is obstruction, I'll get a CFTR. You're not going to get any inference from that. So only vas absence or seminal vesicle absence, CFTR. Non-obstructive, you're looking at karyotypic Y chromosome. So that's the workup in short. And then testicular biopsy, it's only a testicular sperm aspiration. Doing a TESI, which is extraction, off late is not recommended. So you use an 18 gauge needle, you connect it to a 20 cc syringe, and you do multiple pricks percutaneous. Alright, so that's very simple and easy to do. If you are planning for a testicular sperm aspiration, it has to be done in a center where an embryology team is available who can take the sperms and freeze it. Fresh or frozen teaser, the outcome is all the same. So if you get sperms and you don't freeze it, you'll then say there's sperm, now go to a fertility center. They will have to redo the teaser there, which is unnecessary intervention to the patient. So just a request and a point to be noted is if you're planning for a teaser, ensure that somebody from an embryology team is coming and picking up the sample and freezing the teaser. So with that testicular sperm, ICSI can be done. That is something that we need to consider. And if your teaser is not giving sperms, I think micro TESI, as Dr. Durga really elaborated on that, is something that's really giving good results. So if you have to open up the testes, I rather open it in the right way, use a dissection microscope, scan the testes properly because we cannot do multiple micro TESIs on the testes, especially if it is Klinefelter's or somebody with a 1 cc or a 1 cc testicular volume. There's going to, with every surgical intervention we do, you're only adding on fibrosis to the testis, so you do not have the opportunity to do multiple TESIs. So one good micro TESI by a trained urologist with a good operative microscope and a good lab. I think having your lab team knowing how to handle your testicular tissue is very, very important. If they do not know how to handle this tissue, they do not know how to freeze it, I think again the whole effort of the surgeon goes waste. So it is a team effort. Urologist skill is important, equally the lab doing it is also very important. I think these are a few important points that we all should be considering if you're dealing with azoospermia. I think azoospermia doing donor sperm, IUI or ICSI is not the first line of treatment. There's so much more that's changed surgically and even from a lab perspective. We just have to think out of the box and think loud.
Thank you, sir. So we shouldn't do testicular biopsy as a diagnostic modality. So now this patient underwent hormone evaluation. The hormone seems to be normal. Scrotal Doppler showed grade 2 varicocele in both sides. Patient was suggested to freeze 2 samples since after centrifugation we got around 2 to 3 samples, 2 to 3 immotile sperms in high power state. And the plan was ICSI with this. Patient was motivated by a relative to go for varicocelectomy as usual. Underwent varicocelectomy, hoping his sperm count to improve, and came back post-COVID. That is almost after 2 years. So now crypto was total azoospermia and FSH was rising 9.7, LH 7.2. Is varicocelectomy warranted in this case, Dr.
Again, a dicey question. 10 years back, I think we had come to a point that varicocelectomy probably doesn't help. It's more of a surgeon's itch, and you want to operate everybody that we said, let's not do that. But the recent evidence again is changing a little bit. But whatever it is, to keep it simple, let's discuss where not to operate. Where not to operate if there's only teratozoospermia, where your count is normal, motility is normal, only teratozoospermia, you've incidentally picked up a varicocele, do you want to push the person towards surgery? The answer is no. Again, if the FSH, LH, all of that are pretty much raised, the testicular volume is very low, might not be an ideal candidate where improvement might be coming. There's a known female factor which needs IVF ICSI. Again, I might not be keen in operating the person. So I think 3 things if you can take care, that should be okay. And wherever you're getting a varicocelectomy done, again, I would recommend we freeze the semen samples. Always do a lot of counseling to tell them that we're trying to see if we can improve, because varicocele is not the only reason why the semen parameters are decreasing. And again, if somebody's got a normal semen parameters, you wouldn't want to do the varicocelectomy.
So any role of gonadotropins and testosterone in such patients?
For somebody who's not finished the reproductive needs, even if you see a testosterone that's low, testosterone supplementation is a big no-no. That's one thing that we need to write in bold letters. Never give any testosterone to a man who's not finished his reproductive needs. Then what do we do? So if testosterone is low, the alternative is to give HCG. So HCG also will improve his testosterone. Only if the testosterone is less than 300 nanogram per ml is when we would recommend giving HCG. Otherwise, there's no rule. This person had 308 nanogram per deciliter, so I would not really give him HCG. Again, giving gonadotropins only in hypogonadotropic hypogonadism, where FSH, LH, and testosterone are low. There's evidence to say giving them FSH, LH, or testosterone, HCG would help. Otherwise, routine use of gonadotropins or HCGs in every man who's azoospermia or cryptozoospermia will not help or improve their outcomes in any way.
Any role of karyotyping and Y chromosome microdeletion, Dr. Gautam?
Yes, ma'am. Like Dr. Krishna just said that for counts between 5 million or less than 5 million, there is a role for karyotype, and as the ASRM and MESHRE, they do have recommended that for sperm counts within those range, karyotyping, and if the count is less than 5 million, I think Y chromosome microdeletion testing should also be done.
Another, nowadays we use Y chromosome more for prognosticating. So there's A, B, C segments, regions in there. So if the deletion is in A or B, I think you're not going to get any surgical sperm retrieval. There are a lot of publications on that. So A and B, the retrieval is going to be not there. But C, if it is there, the retrieval rates are very high. So I think counseling is very, very important when you're dealing with such men. So you have to get it done. It's a rare thing, but I think we do pick up in a year at least one or two patients who having deletions in this A, B, or C regions in the Indian population. It's accounted to be in between 5 to 10% of incidence. So I think we should be getting, and it helps us as a good prognostic marker.
Yes, especially in if it is C region microdeletion, there are 50% chance of retrieving the sperm. Whereas if it is in A and B and it's a complete deletion, of course there's no chance. And if it's a partial deletion, maybe we can try. So in that case, like when patients have got A and B, it's always better to ask them to go for donor sperms or like. So trial tests are done and 2 to 3 sperms obtained from the left testis which were frozen. Patient explained the need for repeat TSA or TSA, micro TSA during OPU if frozen sperms did not survive. So wife underwent stimulation and husband micro TSA was done and patient conceived in her first FAT. So what is the take-home message? Azoospermia, read the sperm report and check if centrifugation is done, rule out spillage. All varicocele do not need surgery. Trial TSA with semen freezing is backup only. No role of testicular biopsy for diagnosis. Thank you so much for your valuable time. The floor is open for questions.
We'll be happy to take questions while we all are eating, I'm sure. It's way past the dinner time. So I think we will just interact. But if anybody has got a quick question, we'll be happy to take it.
I think panelists has covered each and every point, so our audience do not have any questions. Excellent presentation, excellent discussion by the panelists. We should really appreciate. It's like a knowledge festival. Today evening was the knowledge festival of infertility. So I would like to thank all the panel members with a small memento.
Now we would like to present our panel members, Dr. Vatsala Kamath and Dr. Joylene Almeida, with a memento as an expression of our gratitude and appreciation for the time and valuable input they have shared with us all today. So I request Dr. Durga ma'am to please present Dr. Vatsala Kamath with a memento.
Sir, excuse me. Excuse me.
Dr. Krishna Chaitanya sir to please honor Dr. Joylene Almeida. I request Dr. Pramoda ma'am to please present the memento to Dr. Durga ma'am. Dr. Pramoda ma'am to please honor Dr. Krishna Chaitanya sir. Dr. Pramoda ma'am to please honor Dr. Gaurav Mittal. Last but not the least, I would request Dr. Durga ma'am to please honor Dr. Pramoda ma'am.
Yes, we all are very hungry. Even I am very hungry. So now the last part of it is Thanksgiving time. So I start Thanksgiving. So I would like, on behalf of Oasis, I would like to thank the doctors who are present despite a busy weekday and have taken their precious time to attend the CME today. I hope the CME did help you. I hope you are filled with knowledge. So we would also like to thank all the eminent speakers who made this evening a great festival, knowledge festival. We would also like to extend our thanks to our entire team of Oasis Fertility, starting from marketing, BD, and operation team, who have been working relentlessly to put this program together and make it a great success. Dinner is served. Kindly join us for dinner. Thank you very much.
Video off. Huh? I'll just cover the audience. Video. Good afternoon.